So starting it, I'm Dr. Mark Pamer. I always like to start off this talk just to say this is an awesome technology that we have at our disposal nowadays. It's truly 2014. This makes it about 2114. This puts you so far ahead of the pack as a physician that it's truly amazing. I'm at the point where I don't even want to write prescriptions anymore without knowing what UScript tells me, because I feel like I'm practicing 100 years ago with strychnine for blood pressure, or leeches. This is truly a crystal ball which is available to us as modern physicians and technologists. Personally, I'm a solo practitioner in Southeast Florida. I know Warren discussed it a little bit. I'm board certified in pulmonary diseases, critical care, and internal medicine, trained at the University of Florida and at Rush University Medical Center in Chicago. Most of what I see in pulmonary diseases, critical care, internal medicine are middle-aged and elderly people with a multitude of medical issues. I don't tend to see simple patients anymore, as much as I occasionally wish that I could. Most of them have COPD, asthma, interstitial disease, coronary disease, diastolic issues, pulmonary arterial or venous hypertension, reflux, whether they know it or not, which is causing bronchial hyperresponsiveness and a multitude of symptoms. On and on it goes. Their lipid pictures are usually unrecognized because there's not many people that do the advanced testing with lipo subfractionalysis. Many of their medical conditions are either over-medicated. Many of their medical conditions are unfortunately under-medicated due to drug-drug, and now we know drug-gene interactions. Many times their pain is ineffectively medicated, which is usually our fault many times, with a failure to appreciate the effects, the prevalence of some of the P450 aberrancies, in addition to those drugs which we tend to use. So we see a lot of polypharmacy effects, but I'm not sure that most of us know that we're actually seeing it. So talking about adverse drug events, it's certainly an avoidable medical program. This slide is supposed to show you here the prevalence of these, and you'll see that the number four cause of death in some studies is actually adverse drug events, up to 2.2 million, which is certainly a significant number behind heart disease, cancer, stroke. As a pulmonologist, I always want to put COPD right in there, but apparently, according to the American Medical Association, it actually is adverse drug events. So we're talking about a huge, huge issue in our country, which is under-recognized, to the tune of about $289 billion, no small figure. So what about these P450 variations? I know when we were in medical school, this was something that the pharmacist presented to us, and we all stared at each other and got glassy-eyed, and they were excited about it, but it made no difference to us. And I would say to the majority of us, we still get glassy-eyed when you bring these things up, because we don't have a reference point of which to appreciate these things, so we tend to gloss over them. Well, they're suddenly relevant, and I'll tell you that in my practice, it was a very fast learning curve and an exciting learning curve to be able to see the other half of the pharmaceutical aspect rather than just prescribe things, but then to understand what was really going to happen and be able to accurately predict what would happen in a patient. P450 variations are extremely common. Only 15% of the population is a quote-unquote normal metabolizer across the 5 major pathways, which I show here in front of you. From top to bottom, CYP, the cytochrome P450 system, the 2C19, 2C9, 2D6, 3A4, 3A5. Of these, even if I had to simplify it further, I'd say it's the top 4 that are the most relevant, the 2C19 through the 3A4. In fact, 75% of all medications, now that's ever, of course we use a small percentage of that, but 75% of all medications ever just go through the 3A4 pathway. I would say that the most important ones that we deal with as clinicians go through 2D6, 2C19, certainly 3A4, but 2C9. So very, very important pathway. So when you look at this, you'll see, okay, what's NM? NM is a normal metabolizer. A drug, as we all may recall, may be bioactive when given and then broken down or metabolized, taken to the next step and become inactivated, or it may be a drug like clopidogrel or even hydrocodone or oxycodone, or on they go, which has no real significant activity, but is then turned into the active metabolite as a prodrug. So in a normal metabolizer, you get what's expected. the drug is metabolized at the rate which all the textbooks say that it is. Unfortunately, again, most people have some aberrancy, some polymorphism where they become a poor, an intermediate, or a rapid, or an ultra-rapid metabolizer across these pathways. So what's the prevalence? You start to look, what's PM? It's poor metabolizer. IM, intermediate metabolizer. The intermediate metabolizer is a halfway point between poor metabolization and normal. And of course, then to the right, we have a rapid metabolizer and an ultra-rapid metabolizer. So a poor metabolizer, if you were to give them an active drug, it would stay active for a real long time because the metabolism to break it down would occur at a snail's pace. On the other hand, if you gave the person a prodrug and expected it to become active, that process would take forever and the drug would be extremely ineffective. So looking here, you see that there is a fairly significant amount of intermediate metabolizers. And at least for 2C19, there's a fairly significant prevalence of rapid metabolizers. Given the volume and the numbers of drugs that we use, knowing which of these a drug goes to can be very important in picking the right drug. This would be the slide that I spend the most time on, this one right here. After this, it speeds up. So looking here at 2D6, which is a very important pathway of which many beta blockers and SSRIs go through, you can see that just over half of the population is normal, but over 1/3 is an intermediate metabolizer, and 5% is a poor metabolizer. And if you're dealing with there, as you'd see, a 41% chance of a decreased ability to metabolize some of the most common drugs that we give, this may provide some insight into some of the multitude of positive review systems that we see, such as fatigue, dry mouth, sweating issues, sleep issues, in men, erectile dysfunction, anorgasmia, especially with some of the SSRIs, difficulties, on and on it goes with some of the medications, and why one person may have it but another one doesn't. Looking at the 2C19, you can see there, again, that there's a 24% chance that that person's a rapid metabolizer. All proton pump inhibitors go through 2C19, perhaps with the exception of Acifex, rabeprazole. And you can see there too, if you can do the math at on the intermediate and the poor metabolizer status, that you're dealing with 28% of the population is going to metabolize that in a slow fashion. So I'd like to give some case examples, and these are not made up. These are ones that I've seen in my office. The very first one I call My Patient Vinny, after the movie My Cousin Vinny. And to paint a picture, we like this as colleagues, just picture a gentleman in his 70s from New York, the New York accent. Certainly at one point this was a guy who probably played football, and now life has really gotten the better of him. He's sitting in my waiting room and he's wearing a football helmet, and I thought perhaps, it might be a mental issue. Did he have did he have autism as a child? Was there a seizure disorder? What was up with this guy? He was referred to me for sleep apnea because he was so tired during the day. And I had asked him why he wears the football helmet, and he said because he's so dizzy when he stands up, he keeps falling, and everybody's worked it up and nobody can figure it out. So he was diabetic, and he had hypertension, and he had BPH, and perhaps CHF. So many people get diagnosed with it, and the echoes really is really unrevealing, or perhaps there's diastolic dysfunction, depression, anxiety. He was on a lot of medications. When I examined him, he was positive for Dix-Hallpike, which when I dropped him and put his head into extension, he had nystagmus. So I diagnosed him with benign positional paroxysmal vertigo. I sent him for particle repositioning therapy, the Epley maneuvers, and he really failed those. We did video nystagmography, and it showed central vestibular dysfunction. I sent him for balance therapy, and he still really remained dizzy. Looking at all of his medications here, and I couldn't really fit them all on the screen without making them too small, you can see that there are a lot of medications on here, and perusing the list, none of them really stand out as being, gee, I don't see anything. I mean, we know amiodarone may cause fibrosis, or we know this or that. But when you look at this list, when you first glance at it, there's really no red flags. But I'll tell you, after this presentation, this is a red flag. First off, this many medications should be a red flag, and I think we would all look at it and say there's probably drug interactions in there, although I really don't know what they would be because I'm not trained in that, and I really don't understand what the pharmacist tells me, and it's all sort of theoretical. and follow up in 3 months. But we don't have to be that way anymore now. Now we can find out in seconds and do something about it in seconds. So looking at his list, before I even did the swab on this gentleman, and it's really, this test is a cheek swab, and you FedEx it out and you get the results in about a week. It doesn't cost us anything as the clinician. I just entered in his medications, and of course I didn't know what the P450 analysis was, but at least the software, which is awesome, at least it'll even just tell me the drug-drug interactions. And the first thing that popped up there, you can see that I put his medications on the left. Now, it's obviously not his real name at the top of the screen there, my patient Vinny, but, HIPAA. And here on the right, it shows you what I was looking at, which is that metoprolol, wow, over 200% apparently due to paroxetine. Gee, I didn't know that. Looking down there, I see, okay, ropinirole. He says he's not sleeping well. It's cut down by half. Look at that, by singular. Gee, I didn't know that. And well, let's see, he's on trazodone, and those levels are kind of high. That could cause some dizziness. And the active metabolite of it, which is right above it, look at that, over 200%. So he's really got a high trazodone and metabolic issue. And what's interesting, when you look over to the right, you can see that warfarin and Ranexa boost trazodone levels, but yet it's paroxetine again, which boosts the active metabolite. And tamsulosin levels are increased by 75% by paroxetine. And it hit me. Here's a guy who's got really high beta blockade, and I'm looking at tamsulosin now, he's got really high alpha blockade, and so it's no wonder when he stands up he's orthostatic. This has really become an iatrogenic issue. This explains perhaps why he's failed particle repositioning and balance therapy. So, what does one do about this? Going down the list towards the bottom also, he had some pain issues. I noticed that his lidocaine patch was significantly decreased by singular, by montelukast. So, when I look at this list, I say, well, what do I do with this? Where do I even start with this? This is a normal sort of a patient with a lot of meds. Where do you start? Here's the crystal ball. The other side of the screen, if you look up at the top, you see, well, there's metoprolol. I clicked on it, and it tells me, notes, alternates, mechanism, metabolism. The notes you're looking at there, I can look at a note on metoprolol and paroxetine, on hypotensive drug combinations, et cetera, et cetera. Now, I will tell you that all of this is evidence-based medicine. None of these is somebody's opinion. This will show you what the studies actually show in the pharmacogenetic, the pharmacologic literature, and our medical literature, all of which is peer-reviewed. So this is very, very good information. I wish you could get CME credits for looking at this stuff like we do up to date. But looking at it, then I click here, and I, as I already showed you, you've got a really high level on the metoprolol. And when I click on notes, I can look down here, and here's the evidence-based literature. And look at that, 20 milligrams of paroxetine up there at the top, and metoprolol resulted in a 420% increase in metoprolol. That's huge. I mean, that's really huge. And that's before I even know whether or not he's a 2D6 intermediate or poor metabolizer, which would boost it potentially even more. So next, it allows me to pick alternates, which are safe. On the ranking, anything 10, which you see there, is equivalent to metoprolol. Anything over 10 would be worse. Anything under 10 would be better. So I've got some options here, atenolol, bisoprolol, ace-butylol, any of which would be considered superior to metoprolol. And it allows me, at least on the formula here, that I can click that little plus and swap out metoprolol for an alternative, and then I can see what the differences are instantly across the different medications. So in doing that, by changing metoprolol to, I put him on bisoprolol because there was some history of heart failure, et cetera, and bisoprolol's got good indication and good studies. So that eliminated a number of my drug issues right there. Bisoprolol is sort of at the bottom of the screen there. My next change was, well, paroxetine seems to be causing a whole slew of problems. What other SSRI could I use? So again, I start on notes. There's a lot of evidence-based stuff there. You can read it down. Paroxetine effects with pravastatin, with warfarin, with tamsulosin, et cetera. And I look at my alternates, and number one, okay, I have sertraline, and well, that makes sense. So I swapped out paroxetine for sertraline to see what would happen, and I've cleaned up a whole bunch of more issues there. My next thought was, well, what else? Okay, what about this ropinirole? Well, what's the montelukast? And I asked him, and this like so many of our patients, someone had put them on Singulair, on montelukast. They never really thought that it worked anyway, but they've been on it for years because nobody ever takes medications away. And he didn't really seem to have much of an allergic burden. So let's see what happened. He's complaining of sleep. So by taking away montelukast, then was able to fix the ropinirole issue. Now, looking at this list now, with a minimal amount of changes, I've really minimized drug-drug interactions. And by not doing anything crazy, I've taken medications and moved it over to a sister in the same class, and I've actually potentially here really helped the patient. Now, this is the theory, of course. We all know that theory doesn't always match clinical reality. Just to summarize, I changed metoprolol to bisoprolol, paroxetine to sertraline. I stopped trazodone. He's an elderly gentleman, and I stopped montelukast. And so what happened? I called him a few days later. He said he felt a whole lot better. He was speaking better on the phone. His dizziness had improved by 50%. He was tolerating his CPAP better. He was sleeping much better. His fatigue had improved. The headaches that he'd had completely resolved. He was eating more. I was a little disappointed his dry mouth had not yet changed. But a day later, the primary called me, and ecstatic, really. How did you figure this out? What did you do? And I talked to him about the test and what it showed, and he was really, just overwhelmed in a positive way. Wow. How would you ever have known any of this without, you couldn't figure this out. But here, it was done in seconds. And I tell you, that's really the crystal ball aspect. The next patient that I'd like to show you is, the old adage we got from medical school, all that wheezes is not asthma. And we all heard that. Did we understand it? Probably not. We understood it later on in residency or fellowship or in life. But this is a patient who was sent to me for asthma. And he had moderate shortness of breath, cough, wheezing. He had the perfect history. It was worse in the winter. It was worse around animals. He had nasal congestion, a runny nose. He didn't have any evidence of reflux. He didn't have any acid bitter taste or heartburn to suggest that it was occult reflux. He'd only been on Advair 100. He was on Nasonex, and he was always on prednisone. His asthma control test score was 17, low. Scores from 19 or below are considered poor control. His past medical history, had been told he had asthma, allergic rhinitis, reflux. It was apparently well controlled, hypertension, IBS, and tremors. Interestingly, he was a black belt in karate, and he had some kind of injury, and it resulted in a neck injury, and he'd had some tremors since then, and he was placed on medication for the tremors. He was never smoked. He was a professional. He was a good citizen. Medications, again, no. When you look at him, Advair, fine. It's alfuzacin for gout, Claritin, Dexilant, Librax for irritable bowel, Lipitor for cholesterol, Nasonex for his nose, Primidone for the tremors, Topamax for tremors. I'm sorry, go back. Librax for irritable bowel. Anyway, the Ventolin for the asthma. So, it seems like a reasonable medication list. His physical exam, his BMI was 28. He was overweight, certainly wasn't obese. And his exam was normal, and I always make people blow hard. And he had some wheezes, and so my thought was, okay, he needs better control of his asthma. Let's get him up to 550. I'll stabilize him, and we'll pull back down. So I ordered some pulmonary function testing, some labs, chest X-ray, and thinking ahead. Well, if he doesn't respond, perhaps he's a Xolair candidate, omalizumab for allergic asthma. Maybe he'd need a 24-hour pH probe to see if he really had reflux. So he came back in a month, and really, even with the Advair 500, there had been no change in his symptoms at all. He was still wheezing, and actually his control was worse. His asthma control test score dropped to 13. His chest X-ray was normal. His IgE wasn't through the roof, although it is higher than, it is in the higher normal range. He had some allergies, normal CBC. There was no eosinophilia, none of the worrisome autoimmune conditions that might be present. And his lung function testing was completely normal. So just to review that for us here, his flow volume loop, pretty much normal. Certainly wasn't severe obstruction there. Looking at the FEV1 to vital capacity ratio, whether forced or slow, there was no evidence of obstruction there. You can see the FVC and the FEV1, normal values, no significant response to inhaled beta agonist. If you're really curious, you can see the 6th line down, the mid-flow rates at 2575 was normal. certainly doesn't look like any kind of an early asthma. The maximum voluntary ventilation, the MVV, was normal. Wasn't most likely a neuromuscular disorder or an upper airway obstruction. The TLC, the total lung capacity, normal, and the DLCO, normal. There's nothing on this gentleman's PFTs to suggest that asthma is a cause of his recurrent symptoms. So with that, I said, all right, let's change paths. Let's stop the Advair. This is, I think you have an asthma mimicking state. The most common of which, allergic rhinitis, chronic rhinosinusitis, reflux, heart disease, anxiety, hyperventilation, vocal cord dysfunction. Rarely, of course, something like a Church-Strauss or a Wegener's or some ANCA-associated vasculitis, and on it goes. Well, I decided to get a 24-hour pH probe, thinking that that was the one piece of the puzzle that I wasn't going to be able to objectively evaluate. And I'll remind you, he said he had absolutely zero acid bitter taste, reflux, heartburn, chest abnormalities. So I do a 24-hour pH probe in the office, which is, I tell you, is another crystal ball. And looking at the test, he had 178 episodes of reflux, none of which he felt. He coughed 272 times in the 24 hours and no reports of heartburn. So he clearly had really, fairly severe reflux. And although I'm not highlighting it with a red arrow or a red circle, if you go all the way to the left side of the screen, you can see that the average airway pH was in the back, in the oronasopharynx was 5.7, which is certainly more acidic than what it should be, right at 7.4, like the rest of the tissues. And you can see that the median was 6.4, the maximum 7.7, which is what suggests there's some alkaline reflux as well. But the minimum, it dropped all the way down to 1. I mean, this guy's really dumping acid significantly and doesn't feel it. So there's my asthma mimicking state. What was most interesting about the pH probe, and to walk you through this, the green line there is the pH, and the tracing is the time from left to right. Anything less than 6.5, the pH is considered mild laryngopharyngeal reflux. Less than 6 is moderate. Less than 5.5, severe. And it may go to 5, depending whether you're upright or supine. But regardless, the computer's nice enough to draw our attention to anything below 6, moderate reflux. And it gives us a red line. So you can see that there's an awful lot of at least moderate reflux. And we know there was severe. That's a different screen. I'm not going to show that. I don't know if you can see my arrow, but here in this red, this is where he was supine. So this is bedtime. And any of the blue is where the gentleman had a meal. So what I found most interesting was clearly there's no reflux at all, but then he starts to have a lot of reflux right at 5:15. So his Dexlant clearly has stopped working, and that's when the reflux begins. And when I asked him, gee, what time do you take your medication? He said, well, as soon as I get up in the morning. I basically get up out of bed around 6:30, 7 a.m., and I take my meds, and that's it. And there was no reflux within minutes of him taking his Dexlant, within a half hour or so. And he had no reflux all during the day, and then he had horrible, severe, asymptomatic occult reflux for half of the day. So I thought, well, here's a guy who's probably a rapid metabolizer. So looking at what he ended up being, all right, he was a 2C19 rapid metabolizer, and he was also on a number of other medications. And looking at his path, looking at his actual report coming back, you can see that, well, gee, all the way down at the bottom of the screen, Dexlant has a 51 to 80% decrease in activity. All right, because he's a 2C19 rapid metabolizer, but also because of primidone. And we can look up there and say, well, primidone's not working really well either, all right, because its metabolization is by 2C19. And we can see that primidone is pretty much wiping out Claritin, 51 to 80% decrease. And it's also not having a great effect with the alfuzacin for his gout. And further, we can see that the primidone was having quite a negative effect on his chlordiazepoxide, which was part of his Librium that he was taking for irritable bowel. So I wouldn't have gotten any of this from talking to him. It just seemed that he had horrible asthma. And you can imagine this poor gentleman going on for the rest of his life with more and more Advair and steroids and ending up, I'm sure we've all seen the patient with osteoporosis from all the prednisone who never had asthma. So looking at this, I thought, wow, that's phenomenal. So seeing that there was such a decrease in the Dexelant by up to 80%, and the primidone itself, although it's being knocked down by 2C19, it actually further turns around and stimulates more 2C19 rapid metabolization. So the drug is really downplaying its own ability to work, and yet it's also downplaying the ability of the other medications to work. So at a metabolic level, which you and I wouldn't know, we're just looking at a gentleman who's poorly controlled but not understanding why. And it makes sense. So the first question was, since primidone seems to be the enemy here, is it needed? So I called neurology, and his neurologist said, his tremors were pretty well controlled, and she wasn't even convinced of the need for the primidone. So she tapered it off pretty quickly, and really his irritable bowel symptoms improved markedly. And I changed his Dexelant over to Asifex, which is rabeprazole, which is the one PPI that doesn't only go through 2C19, but goes through other pathways as well, thereby making a marked reduction in the chance that you would have these effects. Well, his cough completely resolved. His asthma control test score went to 25. His refractory quote-unquote asthma was cured, and that was it. So it was a combination of knowing that it was 2C19 and that the primidone and the effects that it was having, and putting him on the right PPI. So very easy. And I tell you, what if I had just stopped like the guy on the bottom, I mean, you just one more chip and we hit the diamonds. And so, let's look at that report again. What else is in there? Where are the chocolate chips? So up at the top of the report there, you see that it gives you, when it comes back within a week or 10 days, it gives you the genotype that the patient has, which in itself doesn't help you and I at all without the software. Otherwise, it's just one more thing to write in our note. But it gives us that, all right? And it also gives us, as I say there, the evidence-based updates available on drug-gene and drug-drug interactions, which is constantly being updated by the people at Genelex. Sometimes I notice it change. I'll know what it said last week, and I'll go there, and all of a sudden it's changed. They really do stay up to date. It will give you the alternatives listed by the risk of adverse drug event, which is phenomenal, which I love. It'll tell me the mechanism of the adverse drug event, why it's occurring, if I was to want to know, and it will go into the metabolism of the drugs if I so choose. This particular one, which is we're talking about lansoprazole here, the metabolism of it, it tells you the substrates, the inhibitors, inducers. Sometimes this gets to be a little bit much for us as the physician with our knowledge base, but it's still very interesting, and you can click on all those references, and it will take you into PubMed and show you the evidence base one by one by one. And I'll tell you that your knowledge base improves exponentially once you start to use this test. It really becomes a bit addictive to see how much we didn't know and how much fun it is to learn and to understand all these cases that didn't quite make sense before. You'll remember in training we always, give me the pearl, give me the clinical pearl. So I say the pearl here, this test is the pearl, but the pearl is the review of systems. And the fatigue that all of our patients say, the dry mouth that you kind of shrug your shoulders at, the sweating, the dizziness when they stand, they have the negative tilt table, they stand up and they say they're dizzy, but they don't have nystagmus and they don't fit the criteria for orthopnea. What's going on with all that? If you could fix those things in one or two quick changes of medications, then you go from zero to hero quickly because you've made significant improvements in the quality of life for that patient that's meaningful to them more than knowing whether or not their HDL went from 38 to 44, which they'll never feel. So metoprolol, carvedilol, the SSRIs, tamsulosin, these medications are so common that we literally develop fatigue error with them. In other words, we see them so frequently that because we see them so frequently, they're normal. They're not necessarily normal. They're not bad, of course. No medication is bad. It just may be wrong for a patient. But there is a high probability that these drugs are going to have significant adverse drug events in a given population. Metoprolol is metabolized by CYP2D6. It is so commonplace to have aberrancies, polymorphisms in 2D6, and metoprolol is so commonly prescribed that, of course, you can expect to see a lot of ADEs from metoprolol, whether you recognize it or not. Carvedilol, same issue. Tamsulosin, same issue. Proton pump inhibitors, same issue. On and on it goes. To go back to this chart that I had shown you in the beginning, let's go back to the 2D6 issue there. So 41% chance of people being a 2D6 poor intermediate metabolizer, which will result in a significant increase in the level of any drug metabolized by 2D6. It's going to hang around for a long time. In regards to 2C19, there's a 28% chance they're an intermediate or a poor metabolizer. Clopidogrel, Plavix, perfect example. If you're an intermediate metabolizer, you're not going to activate Plavix into its bioactive metabolite, which has the antiplatelet activity, as fast. You're going to have a lower amount of bioactive medication. And for the 2C9s, there's a 32% chance there of the same thing. So think of it in 1/3. You don't have to remember 41 and 23 and 32. I mean, just 1/3. There's a good 1/3 chance that your patients are going to be an intermediate or poor metabolizer for most medications. So that starts to change things when you think, which drugs then would be safe, that I'm not going to have to worry about that. And that's when you start to really change your thinking. Now, I came up with this, and it makes sense to me, but it doesn't make sense as much, I think, to the audience when you first look at it. But here's at the top, here's the SSRIs, and then over at the right side, well, there's bupropion, Wellbutrin, venlafaxine effects, or trazodone, which are, used a lot. And where are they metabolized by who? The 2C19, the 2C9, the 2D6, the 3A4. So if you were to know that a patient is a 2C19 rapid metabolizer or poor metabolizer, paroxetine might be the better choice. If you were to know that that they were a poor metabolizer for 2D6, paroxetine would not be the good choice. If they had issues with 3A4, then probably a citalopram or fluoxetine or bupropion, let's say, or venlafaxine would be a better choice. On the other hand, if they were a 3A4 poor metabolizer, trazodone would probably result in significant symptoms. So this becomes very important. Now, you don't have to paste this up on your wall. It's all right there on the website in front of you. I mean, it's at a click, and boom, it couldn't be much easier. Looking down at the statins, same thing. The statins tend to go through 3A4, except for fluvastatin, which is 2C9. Pravastatin is the esterases, and Crestor, rosuvastatin, a very limited form of 2C9. So again, knowing what your patient is would help you to pick the better statin. If your patient was a 3A4 poor metabolizer and you put them on 80 milligrams of atorvastatin, one would not be surprised if they complained of diarrhea and muscle aches. It would make perfect sense. And then, of course, they'll come back and say, well, I'm allergic to atorvastatin. And, well, no, you're not. But now it makes sense. So I like this because I can eliminate the guesswork. And once I have this, I have the person's roadmap. I know how to get where I want to go because I have the atlas. So here's a patient that came to me with chronic cough and fatigue. And the cough was usual upper airway cough issues, postnasal drip, et cetera. And the fatigue, of course, was always a question of sleep apnea, et cetera. But I couldn't help but notice that they were on carvedilol, and it turned out that they were a 2C9 intermediate metabolizer. There's your drug-gene interaction, and the circle blocks a little bit, but losartan also interfered with the metabolism, resulting in a significant increase in their carvedilol levels. So looking at this, one would say, that may be the fatigue and the dry mouth and some of the other issues on that review of systems that all ties back to a drug that we didn't perhaps were able to link that to before. Also notice that losartan is a prodrug. How many knew that? And that the active metabolite of losartan, so obviously named E3174, that the levels of that are decreased up to 50% by a drug-gene interaction and a drug-drug interaction. So, your patient's at 145 over, 80, and it's hard to get them down, and they're on 100 of losartan. Well, one might argue they're not on 100 of losartan. They're really on perhaps 50 milligrams of it if you look at this. So perhaps you change it to a different medication. Also looking, there's clopidogrel, again, a prodrug. And clopidogrel, all right, because of the 2C19 intermediate metabolizer and the 2C9 intermediate metabolizer status, clopidogrel activity is decreased up to 80%. So if your patient's going for a stent, that's probably something that would be quite relevant to the interventional cardiologist, because who wants in-stent thrombosis? Your question might then be, well, wait a minute. Pamer, I've read the New England Journal. I know that there was no, big thing with an increase in adverse clinical outcomes. I know this and that, and I've seen those same articles. And so what does the literature show? Because one journal article does not, of course, make the acumen of everyone's knowledge. You click on the link, and it will go through what the studies show. In this study, it showed this. In this study, it showed this. In this study, it showed this. This study used intermediate metabolizers. This one did not. This one didn't account for that. And it really helps you to guide down the individual evidence base for your patient. And it may say that, look, this all looks really suggestive, but this is too new. We don't know what to do with this yet. It's up to you as the clinician. So I think it's very well written, and sometimes it raises more questions than it answers, but in a good way, because it shows us where our blind spots are. But at least we're thinking and we're learning. So patient 3, I thought was going to be an easy one, the low-hanging fruit. And she came to me for pleuritic chest pain. She was referred by a neurologist. She was morbidly obese. I said, where's the pleuritic chest pain? Where does it hurt? She pointed to the epigastric area and then told me about the acid bitter taste and the belching and the heartburn. And she was morbidly obese and smoking. And I thought, geez, this is reflux. I'm not sure why I thought it was pleuritic chest pain, but that's cool. My kid's got to eat too. I thought it was the low-hanging fruit. So I put her on omeprazole, and her pain was relieved in 2 days. She came back, thought I was the greatest thing ever because her pain was gone. Happened to mention, and oh, by the way, doc, that she'd had a lot of nausea, vomiting, and her depression was worse. She'd seen GI and psychiatry. I know that's not your field, but just thought you'd want to know, and they couldn't figure it out. And I thought, oh. And then I remember, oh, that's right, I swapped her. So, bam, this is what I realized. Okay, looking at her, this is when we met. She was on carbamazepine for bipolar and some personality disorder, and she was on sertraline for depression, and her depression was well controlled, although you can see sertraline, the 4th line down, there was a decrease in its activity from carbamazepine, but she was controlled. It was fine. But then I came along, and I added omeprazole, and omeprazole increased the carbamazepine levels up to 200%. Now, if carbamazepine at steady state was already knocking sertraline down by 50%, and I just doubled the carbamazepine, one could probably successfully argue that I decreased sertraline levels even further. Now, not being a neurologist, I had to look up on up-to-date, well, gee, what's carbamazepine toxicity look like? And what do I see? Nausea, vomiting, tremors, right? Oh, gee, I did this. And the depression, well, I knocked out the sertraline as well. So I apologized to her, and she was blown away that I figured it out when other physicians hadn't. And all I had to do was look on the screen, and it was so obvious. But I doubt any one of us, I doubt most of us, would have known that just looking at the medication list. So it allowed me to change her to something else relevant to her formulary, which was pantoprazole, and her carbamazepine level went back to normal. Her nausea, vomiting resolved. Her depression went back. It improved again, and everyone was happy. And I was very satisfied how rapid of a change we were able to make. So what have we really learned on these couple of cases? I would say the importance of fatigue error. And by that, I mean what you and I sort of blow through on the review. I shouldn't say you and I, but what so many of us have taken for granted in the review of systems are many times, of course not always, are many times it seems to be that they may be related to adverse drug events, such as that dry mouth. I mean, it can't always be Sjogren's, right? The fatigue, it's not always sleep apnea. The cough, the dizziness, the chest tightness, the insufficient pain relief. Many of these end up being due to medication, drug-drug, or drug-gene interactions, which we're unable to see because we have not yet been trained to see that. The asthma is not always asthma. We looked at that. I told you that there's a 30 to 40% chance, roughly. A good third, the patient's a poor and intermediate metabolizer. Up to a quarter of patients are CYP2C19 rapid metabolizers, which makes a big difference with clopidogrel and proton pump inhibitors and a number of other medications. And I'll say down at the bottom, I listen differently now. I've been doing this long enough, and it didn't take me that long, frankly, to figure out what drugs kind of did what. And when a patient starts telling me I had this reaction to this, and this reaction to this, and this reaction to this, I'm hearing 2D6, 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 and I know this patient's going to be an intermediate or poor metabolizer. It's the only thing that would explain the various stars up in the sky that I can now see the constellation Orion. Now I see what's going on. And the next drug I give is not going to go through 2D6, if that makes sense. And I swabbed them, and many, many times it turns out that it's been correct. So this is what the future looks like, I think. I think we're really, when you use this, you're way ahead of the curve. This is the future, at least to me. This is the portal to modern individualized medicine. We were all taught, first, do no harm. And in the absence of this, we are doing harm. It may not be killing people. I'm sure it does occasionally. We all know that. I think for the most part, it just is causing some drug-drug interactions and drug-gene interactions that are annoying and ineffective, but we can do a lot better. So once we know that this occurs, we can eliminate a lot of the harm. So I thank you for listening, and I know at this point I'll be taking questions.